Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Kurt Stange from the Center for Community Health Integration about the Doctor Abides, Simple Rules of Family Medicine. Let's get started. Dr. Dan.
Hey, Faisel, how are you?
I am doing great. And look who we have with us today. So good to see you, Kurt.
Same here, Faisel.
Most of our listeners are medical students or residents. They're trying to figure out what kind of doctor they want to become. So we'd love to start off with your story. What drew you into family medicine?
Well, I don't have anybody medical in my family, and the idea of a doctor who you can see that would just be able to start with what brings you in and try to help was appealing. And then I got to medical school and tried everything out for size. And I liked all my rotations. I thought about doing them and thought I wanted to do them, but not just that. I liked the variety. And so that kept me in it.
It sounds like a familiar story, huh, Dr. Dan?
Absolutely. Couldn't figure out what I wanted to give up, right?
Right, yeah.
Along the way, at what point did you realize that primary care is in itself worth studying much more and defending it as a discipline like any other field?
Well, studying it was not what I was planning on doing. My plan was to become a rural family physician and take care of the folks. And my second week of medical school, I met a woman who was a year ahead of me who decided to go into pathology, and I ended up marrying her a couple weeks after I graduated. And so I had to wait a year for her to finish her training in pathology. I was at Duke, she was at UNC down the road, and I ended up doing a preventive medicine and public health residency. And as part of that, got some research training. And at that time, that was actually fairly rare for a family physician to have research training. And we came to Cleveland, and I still did take care of the folks. I did full scope hospital, delivered babies, taught some people in nursing homes and at home. Did that, but started doing these little studies with that training I had, just little questions that came up in practice. Those are still the most fun studies that I do. You have a question, you want to answer it, you can't quite find what you need to know, and then you figure out how to look at that systematically. Because I had that training, I started to try to get some more funding and do some bigger projects, and got seduced by writing grant applications that allowed me to get money to bring people in and hire people to work with me on things and get consultants and who were the coolest people working on stuff, and I could bring them together. So that kind of seduced me into doing that. So still saw patients, still did some teaching, but ended up kind of looking systematically at things.
It's amazing, these stories. We hear a lot of great stories, and I feel like for me and Dr. Dan, when we get to talk with people from doing all these great things from around the country, like these origin stories are just so inspirational. You could never have planned that. You were never planning on getting into this. Life ended up happening, and you ended up just making the most of it, still delivering babies and doing it all, but also now having this.
Well, I had a different plan, and I think when we do not this kind of podcast, but when you do talks, when someone comes in and gives the big talk, it sounds so like it was all planned out, because we make sense of things in retrospect. And in retrospect, it makes sense. When you're living in real time, it's uncertain. Half the time it feels like a failure. And I think that's helpful to know. It's good to have a plan. It's good to have a direction that you want to go. And it's also good to be open to the opportunities that come out along the way and do that dance.
Wow. What moment early on that convinced you that, hey, family medicine, primary care is one of the most powerful forces in healthcare?
Well, I think we see that every day with just individual people, that it's so healing for them to have someone they can come in, not to figure out, is my chest pain, my heart, my esophagus, my lungs, my musculoskeletal system, just to come in. And so we just kind of see that. So we see that on the individual basis all the time. And my friend Larry Bauer, who's a social worker who you might know, who's spent a lot of time in actually spent his whole career working in family medicine. He says that family physicians do population health one patient at a time. And so you see people sometimes it seems like small things, but those small things add up over time. That investment in relationship and in knowing people adds up over time. Being there for little teachable moments in people's lives, being there for key moments in people's lives, that has a cumulative effect on the health of individuals, and it has a cumulative effect on the health of a community, and then on the population. And I guess the training I got in public health did give me the perspective of taking the large view, and I think that's a lot of the things that we do as family physicians. We have the large view. Even with seeing a person, we look at the general gestalt. What's the most important thing I can do at this moment? Drill down on that, and before we leave that, kind of go back to the big picture. So that iteration, that going back and forth between the big picture, whether it's the whole person or the whole community or the population, and then the individual thing that we can work on and do something about in that moment. That's one of the big values. And this is going beyond your question, but I actually think that's one of the things about family medicine primary care it's one of the things that we're blind to that's real value, is the ability to prioritize. It's the ability to do the most important thing at this moment in time. And of course, all clinicians do that. But when you're doing that about one disease, it's a different thing than it is when you've got the whole broad scope of the person and the family and the community. And so sometimes we're doing care that's kind of good enough care, but good enough care, doing the right good enough thing at multiple moments over time, ends up being great.
So I know you've talked about the paradox in primary care, and the sort of, can you describe that? And then what is that paradox, and why is primary care still so important?
Dan, as I was talking, I was thinking that's what I was starting to think about there. Well, the paradox of primary care is something that Bob Farrar, who's a family physician in Texas, and I both had the same kind of thinking about this. And we realized we were talking to each other, and we decided to kind of write it up. But it's the idea that if there's a whole literature that compares people that specialize in one disease to generalists. And if you look at that literature, you wonder why you have generalists at all, because not surprisingly, people that focus on one thing are better at that one thing than people that do a lot of different things. So name a disease, someone's compared a specialist in that disease to a generalist, and the specialist will do more evidence-based care and apparently higher quality of care in that disease. And then you raise your gaze to the level of the person, and something called the medical outcome study found similar outcomes at lower resource utilization for generalists and specialists caring for the same diseases. And you raise your gaze further to the population level, and you find that systems that are based on primary care have healthier populations, and they spend less on health care, and they have less inequities between the advantaged and the disadvantaged. So that's a really good definition for quality, is better health at lower cost, and better fairness about that. And so the paradox is that apparently there's something more that happens. Health is more than just adding up the parts of care. Good healthcare is more than just adding up the parts. That there's something about this generalist function that we actually are blind to in how we measure quality. We tend to measure quality one disease at a time. And as generalists, we do want to do good quality of care for one disease at a time. But sometimes good quality for the person is not optimizing the care for their individual diseases. Most people coming into primary care, most people coming to hospitals, the emergency department, most people have multiple chronic conditions, usually plus an acute complaint, often a mental health thing going on, family things going on. And if you're just optimizing each part of their care, then people end up on 15 different medications that interact with each other. They end up with overwhelming treatment burden. And we're not always doing the right thing at the right time. There's something else that we do, looking at the whole. And we don't have a good way of measuring that, but that's a lot of what we do in primary care that I think makes a big difference for people.
As I recall, didn't you talk about simple rules for generalism versus simple rules for specialists, right? I mean, we do different things, right? And as I recall, you had the analogy of the birds flying and in the groups that fly together. I don't remember the whole thing, but I remember that being quite interesting.
We were going to have Becca Etz on this talk, and she wasn't able to make it. But the simple rules came out of a study that she did, where she asked hundreds of patients, hundreds of primary care clinicians, about 90 healthcare payers, what matters in healthcare, what makes a difference in people's lives. And then she analyzed those data, and she developed actually a measure called the person-centered primary care measure that is a patient-reported measure that gets at all that. And we can talk about that a little bit if we wanted. But I was helping her analyze those data, and just to give a different angle on it, I brought out this idea of simple rules, which is an idea from complexity science that sometimes in complex systems, something emerges, complex behavior, complex outcomes emerge that you can't see, that you can sometimes describe by some simple rules. And she said, well, what do you mean? And I use the analogy, like you said, Dan, of the birds flocking. There's good models that show that birds flocking. Let me see if I can remember what it is. There's three simple rules that describe that. When birds are first taking off in a group from a tree, they look to try to see where the center of mass is. Where's the emerging center of mass? And they kind of aim toward that. And then they try to be equidistant from the one next to them so they don't run into it. And I'm not sure if I can remember what the third rule is, but three simple rules that explain this complex flocking behavior of birds. So I asked Becca, who's a cultural anthropologist who studies what we do, and I think sometimes understands what we do better than we do, because she really looks at the tacit rules, the things that are behind the things we do automatically. I said, what are the simple rules for a good family physician? And she said these basically off the top of her head. And we did a lot of analyses and refined them a little bit, but she basically came up with it after just wowing all these data. And she said that when we're acting as a generalist, we do three things. First, we recognize and try to make sense of both problems and opportunities. So the first simple rule is just this scanning function. Just try to recognize what's going on. And then after we've done that little scanning function, we prioritize. What's the most important thing, like we were just talking about? And we do that on the basis of what can I do at this moment that might do something to advance the person's health, provide like a health promotion thing that would heal something they have a problem with. Or even if I can't do something that's health promoting or healing, what can I do to invest in a relationship? What can I do to make a connection? So we scan, we recognize, we prioritize, and then on the basis of those, we personalize care based on the particulars of the person in their family and community context. So those three simple rules describe what's not a simple process of taking care of the whole person, but a lot of interesting stuff happens out of that. Then we mentioned this to our friend Will Miller, who's a family physician, a good educated family physician in the Lehigh Valley in Pennsylvania. And he said, oh, yes, and that contrasts with the simple rules of specialism. And we said, well, do tell, what are those? He said, so when you're acting like a specialist, the first rule is you identify and classify disease for management. So you're looking a little bit more narrowly. You're saying, what disease am I good at, and what's the disease I can see here in front of me? And then we interpret that through specialized knowledge, and then we develop a management plan for that disease. We identify, we interpret, and we manage. And I don't think these are rigid. I think we all act like specialists sometimes, we all act like generalists sometimes, but predominantly generalists do a lot more of the generalist special rules, and the specialists do a lot more of the specialist rules. And we need to iterate some back and forth between that big picture of the generalist and the narrow focus of the specialist.
I had a patient this week, a diabetic patient. I put her on a low carb, no carb diet, the keto, and I showed her on Walmart all the different low carb, no carb options that were available. And the hook that I use, or the stick that I use with a lot of them, is around weight loss. I don't think she could really care too much about the diabetes, other than she didn't like sticking herself with the Lantus every night. But the weight loss is what really got her excited. And I do it telehealth, so I was able to show her on her screen. She was able to see how much all these low carb, no carb food options cost, and how it was attainable. It didn't seem like something that she'd have to go to a specialty grocery store for. And so her A1C was hovering in the sevens, like 7.2, 7.3 on 40 something units of Lantus. When she switched her diet, she made a dramatic change in her life. She started having these very low blood glucose levels. And so she went to the endocrinologist and told the endocrinologist, I'm not injecting anymore the pre-meal insulin. I'm having this problem waking up in the middle of the night with the alarm, the CGM going off with these 40s and 50s. Within the first week, the endocrinologist said, no, you should keep like an orange juice. Got her glucose tablets. Just looking at it from that point of view, she called me complaining. And I said, well, let's start backing off the Lantus. So now We've been doing this since January, and now it's March. And so she hasn't taken any Lantus now for, gosh, it's been almost 6 weeks at this point. And now she's got a fridge, with these pens that she doesn't know what to do. And she's worried what she's going to tell the endocrinologist. So I told her, give the endocrinologist my cell phone number, and I'll explain that we had to do something. We could, the solution shouldn't have just been have the orange juice handy or the glucose tablets or whatnot. That, yeah, I don't know any other developed country in the world that'll prescribe insulin to people who are still producing insulin. Is that unique to us?
I'm amazed at how these things that we do, how universal they become, how quickly they become universal around the world. It's amazing. But I loved an early part of that story about how you showed her where to get things in Walmart. I mean, how to make it real, because a lot of people give advice and then a person goes to the store, what do I do? So that's a really important step that you took there. I think that's the difference between that being just good general advice and something that really worked for her. That's a great story.
That was one of the things that Dr. Dan, I remember when I started first learning about value-based care with Dr. Dan, and we started talking about just the affordability of the advice we give. If a patient cannot afford the evidence-based clinical guidelines, is it ethical for us to prescribe or order these things? And I remember, at that time just thinking, wow, it's such common sense. It just makes sense. If they can't afford it, then why are we prescribing it?
And this actually, when you were at UVA, one of my favorite movies is The Big Lebowski. And sort of the punchline at the end of the movie is the dude abides. And you talked about abiding as how important it is for the family physician to abide in healing. And that sort of reminds me what Faisel's talking about. Talking to people about what they can find where they shop is sort of abiding with them. Can you explain a little bit about that term abiding and how that leads to healing and family medicine?
Well, I really wish I'd added the word dude. It was a real missed opportunity there. I just said abiding by itself would have been a lot more fun. There's a different overtone. We talk about sticking with people is another way to say it. Abiding has almost a spiritual quality to it. It has there's extra meaning when you talk about abiding and sticking with someone. And that term became salient for me. I was doing a project with John Scott, who's a family physician, did an MD, PhD in biochemistry at Duke, and then went and set up a solo private practice in Arkansas, grew to a group practice, spent 25 years in practice there. And after 25 years, he said, I've just seen some amazing things that I want to study more systematically. And he went and did a fellowship. He'd done some research as part of the Aspen Network, so he was already involved in research as part of a network. But he went to do a fellowship with Ben Crabtree, an anthropologist who was at Rutgers then. And he said he really wants to, and Ben was so happy to have him there because John was going to take over a bunch of his projects. And I had dinner with him. I said, so John, Ben's real excited about these projects you're going to take over. He said, yeah, they sound good. I said, what would you really like to study? And he said, healing. I've just seen all these people have things happen to them that I couldn't quite explain. And he got more and more animated. As he got more and more animated, Ben started sinking down in his chair because he realized that John had to go study healing and not what Ben wanted him to do. So John went and did a lot of work identifying physicians who were identified as exemplary healers by various criteria. And he did in-depth interviews for several hours with them and got them each to identify 6 patients who had experienced healing, didn't define what healing was, but everybody seems to know what they were talking about, did depth interviews with them. And then we did a lot of work analyzing that. And the thing we looked at is healing relationships. And there's a number of components to that. So first, there's what you bring as a clinician. So you need to have some medical knowledge, and you need to have some mindfulness about yourself and ability to do some emotional self-management and some self-confidence. And you bring those characteristics of yourself. And what patients told us is that these healing relationships involve 3 things, the third of which is abiding. I'll do the other 2 first. First one was valuing, just making them feel valued with a non-judgmental stance, finding some ways to connect to them, have a presence that involved giving them their full attention, paying attention not just to the disease, but to their experience of it as illness, sometimes people talk about suffering with the person. And, we know about this. Sometimes, really 30 seconds into a visit, what you're going to probably diagnose, what you're going to prescribe. And if you just write the prescription, then they're not going to take it. You have to go over the Walmart kind of things. You have to suffer a little bit sometimes with people so they feel like they're heard, they're known. And then you need to the second. So there's that valuing the person. Then there's appreciating the power. We have a power differential. We have greater knowledge of this stuff when we bring that. But I think a lot of what we do as family doctors, we tend to kind of level the playing field. We tend to partner with people, but every now and then we will use that power. We will push people to do things that we can see they might be ready for that they don't quite see in themselves. And then I think for me, the most meaningful was this abiding that people talked about. And it was the hardest one for us to name, but the people had a sense that we were abiding, we were sticking with them by being accessible to them, sometimes at times of, when they really were down. And I think as we're scheduling things now through these call centers and we're getting less accessible to people, that's something we need to pay attention to. Being present for major health events. So if people aren't seeing people in the hospital anymore or whatever, we have to find a way to be there with people sometime during these major events, or at least to know about them. People talk about a commitment to not give up. And they talked about little caring actions that people did. Showing them what it looks like when you go to the grocery store is a good example. Calling people, if you weren't there with them in the hospital, calling to follow up, find out what's happening, calling to follow up with about a treatment. So that abiding, and actually in this person-centered primary care measure that Rebecca and I developed, my favorite item on the 11 items is one that says, "This doctor and I have been through a lot together." And we did a separate study around that item, around people valuing their relationship with their family physicians. And there were two pathways by which people value the relationship a lot. One was just being together over time. Little things over time, you develop a connection, a sense of being known that helps you with diagnosis, helps you with treatment, is healing in itself. I think the feeling that you're not alone when you're ill, or frankly, you're not alone when you're in the healthcare system, because it can be a lonely place if you're just diving in without someone who knows you. So one was just one pathway to valuing the relationship for patients, valuing the relationship was longitudinality, being together for a while. The other was the degree to which people could say, "This doctor and I have been through a lot together." And people that had both of those, they would really do just about anything to stick with their physician. They would pay out of pocket if their insurance changed. They would, because the relationships were so meaningful and important to them.
Again, I'm going to go back to something else that Kurt has a term that family physicians need to stop enabling a dysfunctional healthcare system. And I know we've been talking about the individual patients, but that's how do we keep from becoming part of the problem here as we're doing this?
Well, that's a tough one. You're talking about an editorial I wrote for the Annals of Family Medicine when they invited me to write something for their 20th anniversary of the journal. And I was the original editor, so I thought, okay, I didn't really want to write a nice thing. Listen, 20 years isn't it great? I thought, but this is a big opportunity. They're not going to turn me down. I can probably say anything I want. So what do I want to say? So, and it's a hard thing to say that sometimes we have sometimes become part of the problem as we've gotten more accepted into the medical industrial complex. We being on the outside has disadvantages, but sometimes you become part of the problem. And one of the things that I think that we do is we don't intentionally enable the dysfunction, but we have real people in front of us that are suffering. And what can we do to help? So the system is really fragmented. People designing the systems do it to optimize revenue for the larger system often. And that often they do that in the ways that leads to greater and greater fragmentation of care. We try to kind of pull things together, but it's gotten to such a point that we're holding things together by our fingernails and are at a point where we can't do it anymore. And so I think we have to look for our chances to advocate for that and call that out and call out the problem of fragmentation, call out the problem of greed, call out the fact that we are optimizing the systems for diseases, but not looking enough at the person with the disease. And then I think, as you're saying that students and residents watch your podcast, I think look at the systems in which we're going to practice. Are they supportive of what we have to have to contribute. You look at people that are doing direct primary care now, and I think many people are doing that because they don't want to be a cog in a big corporate wheel. They say, this is the care that I can do, that where I really am integrating and personalizing and prioritizing care for the whole person. They're doing that with smaller panel sizes and lower overheads, and developing teams around that. Now, the problem with lower panel sizes is you exacerbate the shortage of primary care that we have, and I think that's a real issue. That's a real problem. You won't hear me say this term, but the market might actually help that if we really show the kind of care that people can get. People see that it actually is possible to have a doctor that knows you, that takes time with you, that integrates your care, that just doesn't do what they can do in 10 or 15 minutes. I think students see that, wow, that's the kind of care I would like to provide. Systems see, well, that's what people are really voting with their feet. Certainly, we see small employers that are now buying that for their paying the monthly fees for direct primary care for their people. So, I think heroically, family physicians are enabling the dysfunction, but they're not doing that purposefully. They're enabling their patients getting their needs met. And we also have a responsibility when we do have avenues to advocate for larger change, and sometimes to show other ways of care that are better. Whenever we have the opportunity to do that, I think we need to do that.
So if we have a young doctor or young resident who's listening right now to this episode, and now he's walking into clinic Monday morning after the weekend to ponder over all this that we talked about today, what is one thing that this young doctor could do differently in order to practice like true family medicine, if they're not a family doctor, like just true authentic primary care?
Well, I think just pat his or herself on the back and thank themselves for doing what people really need. That's the most important. I want to thank, if you're doing that, thank you for doing that. I just had my visit to my new family doctor because I'm retired. I had to wait 7 months to get in. But she got to know me like she did everything I wanted to do. I feel so much more connected now. I'm actually more relaxed about my health. I didn't have anything bad going on, but if I do, I've got someone I can call now who knows me. That's huge. So just know that your investment in those connections makes a difference in people's lives. Sometimes even when you feel like you haven't really done much for someone, being there for them makes a difference. I think that's the most important thing. I guess as far as getting through the day, my friend Will Miller that I mentioned, this is probably my favorite paper in the medical literature. He has a paper called Routine, Ceremony, and Drama. And Will's father was an old-time GP, hung up a shingle after an internship. And Will had a difficult relationship with his father growing up and wasn't going to be a doctor, wasn't going to be a family doctor. Well, damned if after being a conscientious objector in Vietnam and going off to somewhere in South America for a couple of years, came back and decided to go to med school, became a family doctor, did one of the first residency programs, and joined his father. And he and his buddy from residency joined his father and his partner in practice. And after a year, the old docs were totally rejuvenated by having these young bucks there. And the two young guys were burned out. And so Will's also an anthropologist. And he said to his father and his partner, mostly to his father's partner, he said, I don't know what's going on here. You guys seem so energized and we're just burned out. And he said, yeah, you guys have this training for stuff we picked up on the street. And you learned about the biopsychosocial model. That's great stuff. And he said, yeah, but it's so hard to do it every visit. And his father's partner said, every visit? You can't do that every visit. That'll kill you. He said, yeah, maybe that's what's happening. He said, well, what are you doing? He said, I don't know. Why don't you watch? So Will went and just observed them. And he found that there were these different kinds of visits. There's the routines. Someone comes in with a sore throat. Their strep test is positive. They don't want you to take their family history. They don't want you to dive into all this stuff. They want you to give them the penicillin and they can go home. So great, 5 minutes. You had 15 scheduled. That was 5 minutes. You save a little time there for the ceremonies. And there's two kinds of ceremonies. One are these routine visits, the diabetes follow-up visit, or the well care visit, where we take time to step back and look at the chronic things or the preventive things, to take the long view. And the other type of ceremony are when you either in those visits or an acute visit, you identify something new, a new diagnosis that's going to make a difference in people's lives. Diabetes could be one. You're going to your life's going to be different. You're going to have to change what you eat, change your activity, change your medicine. It's going to make a big difference. You might have to convene the family for that. And when you have one of those kinds of ceremonies, you kind of get some lab tests, plant some seeds, say, who do we need for the next visit? Let's convene the family. And that sets up the drama where, okay, you convene the family. You got a big thing. Listen, who does the cooking here? Someone's going to have to do something different. Or grandma can't live at home anymore. What are we going to do? Those are big deals. So that's when you use all your tools. So one way you get through the day is let the routines be routine. Do a little investment in the relationship because you do it a little bit over time, it's going to add up. And when you have the ceremonies, kind of use those for what they are, get some things started and get on, and then pick your spots, do the dramas, and those are the ones that we tend to remember at the end of the day. Wow, I really helped someone today. I was there at a transitional point in their lives, and I think I really made a difference. We actually probably made a difference in some of those routines. We just don't know it. So know you're making a difference, and save your energy for where you can do the most difference. And just sticking with people, abiding, as Dan says, over time, we're making a difference for people.
Oh, my goodness. Thank you so much, Dr. Stange. Thank you. Thank you. Thank you for a great conversation. This is incredibly inspirational.
Well, we're just witnessing what family doctors do. That's what we're talking about.
What are your thoughts on the Doctor Abides Simple Rules of Family Medicine? You've heard ours, and we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.